very briefly, and I think it's very. I started off with doing a master's in public health program, and I always wanted to make a change at a health system level. But when I was doing my MPH at University of Illinois Chicago, we never had the tools to actually make a large scale impact. So I left MPH with a sense of actually there's so much to do, but how to do it still remain unanswered. So after I did my residency at Cleveland Clinic, I started realizing value from EMR and the data. And then at that time, digital health was not there, but informatics was there. I started seeing how it can really scale the care we deliver to our patients. So I did an informatics fellowship. And for the last 8-10 years, my complete focus has been on digital health and AI, initially at Mount Sinai, now at UC Davis Health. So right now, most of my time is implementing large-scale technology with the help of 650 plus IT team, which we have rebranded to innovation technology. So I love to share what's happening in the field in general, where the field is going, but also distill down to GI-specific use cases. And I'll focus more on what may seem like a future, but actually is happening right now in many organizations. So please feel free to pause at any stage. These are my disclosures. I've been NIH funded, and some of the stuff I've been talking has been built through grants and other endeavors. As Gaurav mentioned, we created the world's first app prescribing platform that builds digital care pathways that's now licensed to Hlth, and AGA has invested into it. I also support other startup companies in the area. When I moved from East Coast to West Coast, it's now been close to 2 years. I can hardly imagine. One biggest difference happened is I was always wearing a bow tie when I was in Mount Sinai, and now I'm not wearing that. So there's a little less formality, but hopefully a little more relaxation in relaxed attitude in a way I'm here right now. But what really enamored me was when I signed my contract at UC Davis Health. I did not see UC Davis Health actually being the signatory authority. The actual signatory authority were University of California Regents. So basically, I was signing the contract with the largest public health organizations in California, which has 5 health systems: the UC San Diego, LA, UCSF, UCI, and UC Davis Health, as well as all the computer science schools like University of Berkeley, as well as the management schools. So this has opened up just a great opportunity to actually do things together and learn from each health system, and has been a great learning lab for us. Just last week, UC Davis Health was ranked as #1 in California in terms of digital health most wired status. And that's been a 2 years effort for us, for 650 plus IT team, which we have structured, called as innovation technology. And now we have this learning laboratory where we not only use EMR and scale the EMR, but actually have been one of the biggest users of telemedicine. In 1992, we had the Center for Telehealth being blessed by Governor Schwarzenegger. We're also heavily investing into digital first strategies like digital front door, which I'll talk about, digital monitoring, as well as open partnerships with many societies in that regard. But why digital health and AI becomes a very key question. So I want to start off with that part. I think most of us, human brains is wired to think linearly. 1, 2, 3, most of the growth in startups, traditional startups happen linearly. Most of the businesses scale linearly, most of our healthcare organizations for sure. And if you expand your private GI group, your 4 people group, you expand to 5 people, 6 people, right? But really, the real benefit of a data and digital world is, as soon as you get into that world, and nearly any sector you get into that world with digital and data, the growth is exponential, which means 1, 2, 4, 8, 16. So an example is, if you have 16 squares, it's not like you reach 100 or 200 by the time you reach 16 squares. If you grow exponentially, you actually reach 18 quintillion rice grains, which is 18 raised to the power 10 raised to the power 18, which means 50 times the world's rice production. So if you have an exponential technology, you can start something and you may say, oh, it's impacting a little bit. but you can never predict how far it will go because the growth is just enormous. And that's where we feel care delivery can go if we really unlock it. So I've worked with these organizations to create some definitions around digital health, digital medicine, and digital therapeutic. Digital health being the broad field of anything in healthcare and digital. Digital medicine is something which has a clinical evidence to it, which we can trust. And digital therapeutic is something which has real world outcomes attached many times with FDA approval. But the real value is the digital medicine field can really take you beyond this one-to-one care. Right before the COVID happened, the only way for anyone to provide care is to be in the same room at the same time as a physician. With telemedicine, with COVID, we were able to unlock to some degree the space dimension. So people can have video visits anywhere they are. Now with digital care, we can finally unlock the time dimension, which means if I have to explain over 3 minutes how to better prep for a colonoscopy, I can completely unlock that time dimension, and I can have a bot already engage patient every single day and guiding it instead of me calling the patient on a single day, right? And I don't have to do it for one patient. If I do it the right way using a digital bot, that can do to millions of patients at once, right? So that's where we really believe the power of care can move from one-to-one to one-to-many care. And really the biggest source for that is not only the technology from our side, from physician side, but technology which is in the hand of the patient. And one single smartphone has 1,000 times more processing power than all the NASA supercomputers, which led the man on the moon, right? So we just have to unlock these technology. And how we are looking at that is all the technologies you see on the right side, the digital front door, therapeutics, decentralized trials, machine learning, ambient intelligence, voice commands, we are looking them as scientific principles of digital medicine. Very much like we in our medical school learned anatomy, physiology, biochemistry, we are fundamentally evolving new subjects of digital medicine and inventing them and embracing them and testing them in care. I'll focus for this discussion on the top ones which have really best applicability to the world of GI. But as we are doing it, we're also creating new science. So I'll just give an example of that. Somatics is an Israeli-based company, and typically there is no good biomarker for smoking except getting a blood work and assessing tobacco levels in the blood. So they created a ring which, with the AI and the gyrometer and the positioning meter, it can actually tell whether you're smoking versus you're combing the hair or you are shaving, right? So it has now been able to create a unique digital biomarker, which has nothing to do with the biological science, but using AI and computer vision and gyrometer, they are able to predict with a very decent accuracy you are smoking versus not. And what's really important is you can then combine where you're smoking, whether it's home versus work. And then you can say, oh, you're smoking a lot more at home. You need to talk to your wife more about this. Or this is your boss. You are in Dr. Arora's practice. You really need to talk to him. He's giving you a lot of stress. So you can actually improve the outcomes in a very contextual awareness and create new sciences away. But the number one challenge, I believe, which you all face, which we face as a health system, is this very fragmented digital health ecosystem. We wish it was easy like an EMR. Hey, there's one EMR, it will do everything. But there is no application which can actually do everything. So there's just a preponderance of this. And that creates a very big gap in how to bring things to the fruition. So what we had worked over the last many years is bringing and connecting all those technologies which are evidence-based into one we call as a digital health formulary within electronic medical record. So very much like you can prescribe a medicine, the medicines can be PO or IV or rectal. They can be any mechanism of action. Similarly, you can prescribe any digital channel, a bot or an app or a digital monitoring device or a bot or an AI tool directly to the patient right from the EMR. So basically, you need a convergence at the point of prescription, and then you need convergence at the point of the patient. So you can activate a patient, engage a patient, and really monitor a patient through all those tools. So this was a lot of the work that we had done, and now AGA has partnered to make this toolkit available for GI practitioners and researchers. And a part of this digital health formulary, which brings all the tools together, is based on AI and data platform, which is in the cloud. So if you hear things about the cloud, it basically means you do not have to install a physical server or a computer in your office to actually activate any new application. You don't even have to have any physical footprint. You can actually get it directly from the internet, and you can leverage the latest technology. And the benefit of that is enormous, because not only it's much more secure, it's actually much more scalable. And if you need to expand from one app to the other, you can do it at the point of a click of a button, rather than someone coming to your office and installing a new server in that regard. So I'll just take a pause here. I think this is just a background context. Over the next, I would say 20, 30 minutes, I like to go deeper into applications of it. And maybe I'd love to hear from you, which of those you're already using, which are the things you are thinking of using, and which are kind of just a black box for you, which we can demystify today, right? I will not touch too much on computer vision, NLP, and ambient noise monitoring. In the interest of time, I'll focus myself mostly on the top 4 in that regard. Is that something good to cover? If I don't hear, I'll just keep on going, knowing.
Go ahead, Ashish. Go ahead.
Right, fabulous. Thank you.
And one more thing, when you get a chance, can you elaborate more on the EMR toolkit that you guys are partnering with AGA on?
Yeah, absolutely. So I'll go through the digital navigation part, but just as a context, if I go back to kind of explain that. So the toolkit with AGA is actually creating GI-specific digital care pathways, which can support chronic disease as well as endoscopy practice. So basically, AGA has worked, and they had a whole committee which helped us create around 100+ GI programs, digital care programs, across all colonoscopy, upper endoscopy, and advanced endoscopy. So if we have a colonoscopy appointment, it will take the best practices from AGA, and automatically a text will go and an email will go to the patient. We'll inform them how to do over the next 10 days in order to be prepared for colonoscopy. And then it guides through if they have to change their appointment or what have, they can just text back. It automatically acts on that behalf. So those pathways are all created for most of the procedures. And we have chronic diseases for IBD and few others monitoring programs there. The other thing which AGA has launched is colorectal cancer surveillance program. So you can actually reach out to all the patients who are Cologuard positive and convert them into colonoscopy. Or you can find all eligible patients now above 45 with a change in the guidelines and engage them for either colonoscopy or for Cologuard or for stool occult. And anyone who is positive comes back to colonoscopy. So you can actually create your programs, but AGA has worked extensively to create those best practices, so you don't have to worry about that. So I'll share the impact of those programs and how health systems are leveraging it over the next 20, 30 minutes. So one of the things is you'll be hearing this term called digital front door. And digital front door means very much like you have a physical office space where patients come in. We do envision most of the interaction which will happen of the patients will not be through physical space, initial one, or through a phone call. It will actually happen through a text, through a patient portal, or through a chatbot or virtual care. And just to show some of the examples of that, many of you may have turned on appointment reminders by now, but you can go very deep beyond appointment reminders to actually engage the patients. So we created a framework called as the Trust, targeted reach using tailored health messaging. We have a full developers who build bots for us day in and day out as part of UC Davis Health. and we can customize a bot experience for nearly anything. So for example, this is the experience we did for COVID-19 booster, where we were able to find all the patients who are eligible for booster, send them a text message, automatically they went through the bot and the experience, and we scheduled an appointment for them if they were interested. We were able to reach out to 30,000 people just at the click of a button, and 1,000 people over the next 8 weeks already got converted into getting the COVID-19 booster. And these people were later in the period, so they were already had decided not to get booster. So we were able to change their perception and get them to a booster just using automated channel. So there's an estimate it would have taken us 30 nurses over a period of a month to be able to do that, what we were able to do just with a bot and the experience of the bot. We did something similar at Mount Sinai before. This was the peak of the pandemic when a lot of patients were calling what to do with the COVID. Very early when the guidelines were not out or very confusing, we actually ran out of all our phone lines. We recruited medical students to man our phone lines, and they got sick as well. 30% of them were not available. So we actually created within 2 weeks a bot which will automatically reach out to 1 million patients and enroll them into a digital monitoring program. And through that, we were also able to educate what to do, what not to do. So we were able to get 55,000 people automatically enrolled in a clinical trial without a single coordinator, right? So that's an enormous value we can do, major efficiency gain and automation for our practices. So I see them all as tools we need to know about. And then at the relevant, when we have challenges, we can then bring on these relevant tools to address those challenges. So I'll take a pause for bots and this, and hear if there's any questions in this regard. Okay.
I have one question, Ashish.
Mhm.
Is this something, so the committee that, most of the committee members are here, we are kind of like in micropractices, small practices, solo, or just a few people. So is this something that's accessible to practices our size, or is this something that only kind of like large practices or big institutions have access to?
That's a great question, Gaurav, and I think that always comes up, right? So the automation program, when we started working with AGA, one of the specific requests that AGA had was to have it for community practices of any size. So we actually, even though we had built in Mount Sinai and there was large scale practices, we actually customized the program. So even a solo practitioner can launch it, right? So where I think the customization happens is, it's actually in some way very easy for a solo practitioner, 1 to 2 practitioner. The reason for that is a lot of our effort in larger practices is not on integration. It's actually on taking all those multiple pathways and multiple patterns which each of the GI practitioner has for each of their practices. And reconciling them becomes actually a few months job. If it's a 2 or 3 people practice, they already have a very well organized 2 or 3 things they do in bowel prep. That's much more easier. Their programs are much more easier. The other reason it's actually easier is you can see the impact immediately. In a very larger practice, for example, at Sinai, we had around 30, 40 physicians at a very big practice. It took us actually at least 6-9 months to see the impact because there's so much going on and we had to measure that it has to be enough, big enough. In a smaller practice, you will see the impact or lack of the impact within a matter of 3-4 weeks, right? So you can immediately make a decision, oh, this is the right thing, you want to scale it further, or this is not the right thing. So in a way, it's easier in the smaller practice to do it. The only thing that that comes as a question is how much integration you want to do with the EMR. So some of the smaller practices don't want to or don't have resources, IT resources, to integrate completely with the EMR, or they don't have knowledge in that regard. So we have been able to suggest a process where you can still link the patient appointments without going through full integration. It just requires 5 minutes for a week. One of the nurses can do it, or MAs can do it. And that can take the role of a deeper integration. And ultimately, if that's the right thing, you can work with the EMR vendor and it can be done as well. So it's just a matter of little customization, but I believe there's many things that you can do actually easier in smaller practices and micro practices. Yeah, does that help you, Gaurav?
Yes, thank you.
Sure. Let me go to the next part where I think a lot of the value creation lies. And I'm just giving example right now of the colonoscopy part, but you can virtually extend yourself to any digital role and you can make that happen. And I'll share the example. For example, you can say, hey, and I'm sharing this from real examples. I've worked in Mount Sinai and at UC Davis right now. I want to look at all my Barrett's patients and are they coming at the right recommended interval? And if they're not coming at the right interval, how can we automate them back to my practice and schedule them? So all we need is a data dump of the Barrett's, and we can then create a digital program. And there's already a program created, which will automatically call the patient and schedule them, tell them about warning signs and why they should come back and motivate them. You can say, hey, I want to have a process to monitor all the IBD patients, and whoever is not doing good automatically bubbles up so I can see them earlier, right? So wherever you feel there's a bigger quality gap, or you feel there's something that needs to be done, but you don't have resources, or you're spending so much resources calling the patients, engaging with the patients, decreasing the no-show, but that's like a brute effort by the nurses. Can you automate that and free up that resource for something? So I think part of it is part of me just to share some of the things that have happened, the use cases and how people have created value. But you can actually then look into your practice and say, we have 5 other use cases. Can those be helped as well? And that's where the transformation journey starts, right? So one day I was scoping at Mount Sinai, and I've had 6 out of my 7 patients who had poor bowel prep. And of course, you already, and part of it is little academic practices, there's a little bit increased incidence of poor bowel prep, but sometimes things have to get so bad that you then start acting. And that was probably the day that, all barriers got broke. Then I said, oh my God, we have to do something about it. This is around 4 or 5 years ago. And then we did a whole and understanding with respect to financial pathways and say, what is the gap here? So we found around 6 to 15% of patients have no-show or delayed appointment for their endoscopy procedure. The literature quotes anywhere from 15 to 25% of patients with suboptimal bowel preparation. I know, Gaurav, your practice is an exception. But it's a lot of the brute effort that your care team has been able to do. But most of the other practices suffer from suboptimal practices. And think of a $2,000 to $3,000 procedure. There is no other procedure in US healthcare system which is that high a cost with that big failure rate, right? So when I tell this story to a lot of the health plans, they are completely taken aback, right? The percentage of patients who come back to ER, a lot varies on the settings, but many of them is just they had to pass the gas. And they come back because we write in our stuff, if you have too much pain, that's not getting better, come back to the ER. But by the time they come back, endoscopy center is closed, so they show up and they stay in the night. This was really eye-opening. There's a study from Hlth from Brigham that 30 to 70% patients were not coming back at the recommended interval, right? And then we did a search at Mount Sinai. We found 20 to 30% patients with positive FIT or Cologuard were not even offered a scheduled colonoscopy. And then there were 30% patients who were ordered a colonoscopy by primary care doctor who were not scheduled. And you may see many of those patients as a referral, that you may be made a referral, but you may never see the patient, or the patient may never return the call. So we have created a whole referral pathway where the patient just gets a referral directly through a text and it comes to your practice directly. So again, these gaps really, we actually looked at a $4 to $5 million opportunity at Mount Sinai every year alone, if we completely address it. And we knew we could not completely make it zero. So we estimated the max we can do is decrease it by 20, 30% or 40%, and we can have a $2 to $3 million opportunity of savings at Mount Sinai. So initially we tested it in actually Arizona Center for Digestive Health. We were able to launch this digital care plan. This is pre-AGA, and we were able to show 24% improvement in bowel preparation, 50% reduction in aborted procedures, and 92% patients satisfied. In fact, the patients, when they were automatically guided through the colonoscopy, they said this was the best part of them getting their experience. We also had this private practice then set up a way that any patient who was really satisfied automatically was able to leave the ranking on Yelp or on Google. And they were able to change the ranking from 2.5 with 10 patients to 4.5 with 100 patients within a matter of few months. So this was a very successful pilot. And then we started implementing them and large scale adopting it from Mount Sinai. And that's where AG engaged with us to actually enable it to be done outside Mount Sinai as well. So this is the study we presented in DDW on people who were engaged with the program versus not. We were able to find that patients who engaged with the text-based program, they were 4 times more likely to complete colonoscopy, not just poor bowel prep, complete colonoscopy. So this, in fact, the single most important predictor for patients showing up and completing colonoscopy when they were offered was engagement with the digital care plan, and not age, gender, or any other insurance status. So after that, we also further enhanced the program to say anyone who is not engaged, bubble it up in a dashboard, so then you can make a phone call. So we moved from completely manual to testing a completely automated to then adopting an automation first approach with digital pathway with the backup of a phone call to engage nearly every patient that's needed. So basically, through the EMR, patients who are already scheduled get a link right on their phone on behalf of that physician practice. So it's completely white labeled. When they click on it, it automatically drops a calendar invite right on their iPhone or Android. It gives the micro-learning videos from AGA on why it is important and how to actually take the bowel prep. And we have now, with the help of AGA, have all the bowel preps and their specifications built into the care pathway. And then if patients are not engaged or engaged, it all bubbles up into a dashboard. And if people are not engaged, it gives an alert to the care team to call the patient or do a video visit. Maybe there will be a no-show, and you can actually replace that slot with something else. So this program has now been scaled. With the AGA help now, we were able to implement in New York City Health and Hospital, and they had a very high no-show rate of 27% in inner city New York. And this is the result that was presented last year in DDW, where we were able to show the no-show rate before this procedure versus as soon as we launched the digital care program, the no-show rate decreased to 3 to 4% as compared to 27.8%. So 83% reduction in the no-show rate just by launching this program, completely automatic. So we were able to then do, this just shows the example of pre-intervention versus post-intervention, the impact. Then we did some cost modeling to show how much savings you can have through this process. And we were able to show, and I'll just move the screen a little bit. So we were able to show the number of colonoscopies saved were 23.7 based on the no-show reduction. The average payment they were receiving was $2,400. Give me 1 second. My kids decided to just print the paper at the same time I was giving a talk. And then annual potential revenue impact we were able to show was more than $500,000 for this practice, which was around, I think, 7 practitioners in that. So typically we feel if we do it the right way, there can be a savings just with this pathway around colonoscopy alone, around $100K per physician to $250K per physician if you have nurse practitioners and others as well, based on the practice. So now this is scaled to upper endoscopy and others as well. So this is the overall impact on the program as it got scaled from the one endoscopy center to the entire hospital. So I want to take a pause here. So what we have built is actually a calculator with a sliding scale. So if your bowel preparation, if your no-show rate is not, whatever your no-show rate is, whatever your bowel preparation rate is, whatever your nursing staff is, we are able to put that number and then say how much we can expect savings. Not every practice gets equal savings because some practices are run very efficiently. So there we may be able to see 50 to 100K per physician saving, but some practices which are very inefficient, you can actually have up to 250, 300K savings per physician in that regard, just based on colonoscopy, not even expanding to entire endoscopy center and full appointment reminders. So I just want to take a pause here. I know this is the time when people ask a lot of questions because they're now thinking, oh, this can happen in my practice and how I can enable this. So I just want to open up for any questions at this stage. I know there are a couple of things in the chat. So let me have the liberty of just, I'm not able to open the chat right now. I don't know, Gaurav, if you are able to see or anyone else in the chat.
I don't think that there's any question in the chat.
Okay. It was just an alert to me for some reason. Okay.
Yeah.
So questions from anyone at this stage before we move on to other aspects?
So Ashish, can you talk about the cost of this digital navigator program?
Yeah. So I think there is an enterprise cost for bigger health systems. But what we also allowed is there are around 7 or 8 small practices using that. I don't know the exact one, but I can give you an estimate. I think there's some base cost of $100 to $200 per month per physician. And then it is, I think it's $2 per colonoscopy or something of that nature. So it's pretty minuscule because they are able to work with AGA, a specific pricing for AGA members, something we can do with TSGE as well. So basically, it's if you are able to get the value stream, and you can stop anytime if you're not getting the value stream. So this is mostly what we were able to negotiate for smaller practices, mostly a pass-through cost. And the caveat why we were able to do just a pass-through cost was that this does not include the integration cost, which is typically 5K or say 5K or so. So they are able to leverage the smaller practice team, just sharing their patients who are scheduled for that week, that list, and they're able to automatically engage in that regard. So it's a pretty low cost per physician in that regard.
So basically, you don't have to integrate with the existing EMR. And as you're saying, you can just provide a list of the patients who are scheduled. And then I sounds like manually enter somehow. And that will bring down the cost quite a bit because you won't have to pay the initial integration cost.
That's correct. That's one of the main things. And then for smaller practices, they say we can't have 24/7 support and those kind of stuff, right? So that decreases the cost as well in that regard. So the manual process is only 5 minutes. Basically, you just export the list CSV or Excel, which is for patients which are scheduled over the next 2 weeks. And that list just gets updated using a cloud platform. So you just have to just upload it and that's it. But you don't have to type in the name and the person and who it is. You just forward that list and it is done. Now, if you are using many of the other EMRs, which you may be, and you say, hey, we even want to do complete automation, we don't want even that someone spending 5 minutes a week or two, then there can be integration with the EMR as well. But what we suggest, if you're a smaller practice, just create value off the bat, tweak it, see if it's working, and then you can decide. But for most of the smaller practices, we had 8 out of 9 decided just to continue that weekly process, the bi-weekly process, and they're very satisfied.
So this study is for an endoscopy set, not for a practice, right?
So we extrapolated that. So you can take it both ways. So for example, what I'm showing the example is just from endoscopy center, but I will show you in the subsequent slides how you can add the similar stuff for no-show reminders. So for example, we have shown 30% decreased no-show rate for the ambulatory practice as well. So it's the same toolkit. So again, this is the concept of toolkit.
Endoscopies you're talking about, like a office endoscopy or office visits?
Yeah, so I was talking about, it's the same toolkit, which has a program for office visits, and it has a program for reminding telehealth visits, and it has a program for doing endoscopy center, right? Endoscopies. You can use it for endoscopy
Most of
in
the
the
EMRs
office.
have automatic reminders for the patients. And also another question on the same thing is, this GI endoscopy center or even the office, this one, is there any study for the micropractices?
Yeah, so I can share the results. I thought,
Micropractice less than 4 physicians in the practice.
yep. So this first use case, which I shared, let me come back, was actually done in a 7 people practice. The
That's not-
Arizona thing. This one is a 7 people practice.
Do you have any for less than 4 physician practice?
Yeah, so there are 2 practices in Boston, which are, I think, 4.
Do we have any
And
study?
yeah, so there is a data on that. So what I will do is I'll connect you with Rick, and they'll be able to share the data from that.
And that's for the endoscopy center, right?
That's for, they have a endoscopy center where they do endoscopies. Those 4 people practice, yes. It's a shared endoscopy center.
Yeah. Because most of us are solo practitioners, and I don't know whether this will apply or not. So,
and how do you do? So one is you will be able to take the office modules for appointment reminders and for no-show and others. And if you have, do you use Provation or do you use what endoscopy software?
we use, what is that one? GMed, G-Gastro.
Yeah. So the G-Gastro is actually very intuitive. So you just take if you document in G-Gastro itself, then it's just a matter of, you can actually work through G-Gastro very easily. So all it requires is a digital connection, right? So whoever your office manager is for G-Gastro can generate a list of all the patients scheduled for any procedure over the next 2 weeks. She can just export that list and it will automatically engage the patient. The initial onboarding team, it actually takes your office practice location, map it to a geocode. So they do all the work pre-hand and your name of the practice and everything. So patients get engaged automatically on behalf of you. And if they are not engaging, the data comes back in a dashboard to your office manager. So you can turn it on. What I would do is I'll share some contact details so they can do initial feasibility analysis in that regard to see if it's working or not working. Right? I think the key is to see what are the major gaps you have in your practice, what are the opportunities for improvement, and based on, this is now in 7 academic centers, 4 or 5 larger practices, community practices, and 3 or 4 smaller practices as well. So total around, across West Coast and East Coast. So you'll be able, and total around 3 million patients are being touched by this platform nearly every month. So there's a lot of knowledge that has been generated using how to engage the patient and get the value stream. Yeah. Any other questions? So I want to talk a little bit, if there are no questions, on digital therapeutics monitoring and decentralized trials. I do not know if any one of you are involved in trials, whether it's IBD or others.
Some of us are, and some of us are thinking about getting involved.
Okay, so one of the things that pharma looks for, or the CROs look for in the clinical trials, whether that's for NAFLD or IBD or others, is, does the site have capability to do trials? Does they have numbers to do the trials? So one of the things that we have done is actually turn on monitoring arm for IBD, and then turn on a digital trial recruitment arm within that monitoring arm. So the patients can be automatically recruited. So talking about the digital toolkit, it's not just limited to the tools that are built by AGA. You can actually use the same toolkit to integrate with other digital tools that are coming from anyone. So I was talking to Mahana app, which is now FDA approved for IBS. It goes through the cognitive behavioral therapy. Many of your tougher to treat IBS patients keep on asking more and more stuff, but we don't have much to offer sometimes. So I have found this is actually paid by the payers. So all you have to do is prescribe this app, and the patient automatically then submits their details of their health plan. And if health plan approves it, it's just to add an extra tool that you can offer to the patients, right? So you can offer this as well. So we have a similar tool for IBD as well, where we are able to prescribe an app to the IBD patients, and it teaches them about all the IBD quality metrics, but also keeps track of the electronic patient reported outcome, EPRO. This is our initial study where we were able to assess how patients do on monitoring and whether they start to get better based on the quality metrics. And this has led to this large-scale effort with University of Chicago, Montefiore, and 5 other health systems, where every patient that's being in IBD is being offered this app. So they are engaged. They get to know when they are controlled, when they're not controlled. And when they're not controlled, the data comes back to your practice to say, hey, this person is not controlled. This may be an opportunity to change the medicine or to actually bring the patient for a telehealth. So that has been a very big efficiency gain for the health systems to find the patients who typically are lost to the practice many times, and they come up with the surgery later on. So you can engage nearly all of your IBD patients in that regard. Now, the other really good part of that is because now you're collecting data on their EP, electronic patient reported outcome, and their symptom burden, you can then now use them to recruit right from their home. So you can now just, and we did that because we had this program live. We were having struggle recruiting in a clinical trial patients. We only recruited 17 patients over 6 months. But because we had around 1,300 patients in this program, we were able to reach out to them, ping them about this study. We were automatically able to find patients based on their response to the monitoring program, that they were controlled or not controlled. And not controlled patients, based on their biologics data, they were automatically offered to be recruited into the study. And we were able to get 206 patients agreed to enroll within a single day, right? So again, there's a lot of efficiency tools, the same engagement tools, which are on the clinical care side, render themselves very nicely to be extended on the clinical trial side. And this is something that's evolving. And we are actually on a listening mode at UC Davis and others to say, how can we create a largest clinical trial network enabling GI micropractices to be involved into the clinical trial? But once we know the key factor is we cannot engage if we don't know the control status of the patients. The moment we get to know through a digital engagement, they're controlled or not controlled, we can offer them recruitment. And we ran some numbers that on an average, if you are able to recruit patient to IBD study, it's somewhere between $3,000 to $10,000 that you are able to benefit from. Of course, there's investment in terms of coordinator and others. But if you run the numbers, you are able to kind of really be part of a group practice in a way. So even though you are your own clinical practice, you can be part of a larger group, which is managing the clinical trial recruitment on behalf of you and enabling them. So that's something that we are started our discussion based on the need, and something that I think I love to hear from this group, if that's of interest to them, as something that we should take forward. So this is how it happens. So once we find the patient is eligible because they are not controlled, we are able to offer them enrollment right from their phone, including e-consent form. We are able to track their symptoms, their medication, give them the gift cards, and actually get back the data back into the clinical trials. So just want to hear if there's an interest of that before I kind of try to summarize the discussion. So I'll just end on a few notes and then maybe completely open up for discussion. We've launched a digital GI community. In fact, there's a digital GI a conference that happened in AGA in Bethesda 2 months ago. We'll be launching a whole conference, a whole workshop in DDW. I'm hoping it gets approved. So many of you would be able to actually avail informal workshop over four hours, getting to know all the digital health tools and the AI tools which you can use in your practice. The goal is really what we call as reduction to practice. The key thing which we're working with AGA is we don't want to be like a guideline or a best practice that's written in a paper and rarely achieved in a practice. We really want to go that we are able to reduce all of those tools to our practice. And a lot is offered in the community GI practices. So till we are able to engage community practices and create value from them, the mission is not successful. And AG actually has taken that in a very positive note in that regard. So creating this whole community around that. So you'll hear more in the DDW on that part. I want to leave you with a couple of emails. One is you can shoot me an email if you're interested. I'm happy to connect you with folks. If you want to reach out directly to learn more about this toolkit, there's engage@rxl.email. You can directly use as well. And if you are, what we may try to do is I'll talk with Dr. Gaurav Arora to see if we can have for TSGE practices, and I can advocate for first 30 days as just as a free pilot, so you can just turn on and see the value stream before turning on any payment in that regard. So we can do that as part of a group practice. If you really want to do a digital way of engaging, you can actually scan this QR code. We launched this at DDW. Or you can actually text to number 64722 right now and type DDW, and it'll automatically take your details and forward to the right team so they can get back to you, right? So this is kind of similar to the tool we give to our referring physicians in private practice, in primary care. So the primary care doctor just gets this something similar with the name of your practice, which patients just text, and it connects to your practice right there as an e-referral form. So you don't lose any patient as a referral form. So again, just to show the digital tools are pervasive, you can use them in very novel ways. This is one way that we've started engaging people if they want to really connect and start adopting. And part of it is it's so easy that you can just text this number now, and this is how your patients will be engaging as well. Yeah. So in the interest of time, I want to just take a pause and just conclude the presentation. I will share the deck with you. Happy to answer any one of your questions. I think we have a few minutes for any questions in this regard.
Ashish, first of all, thank you very much. This was an excellent presentation. And I can see so much potential for the platform and the technology that you described. As you were just talking about referring physicians, I was even thinking that maybe like a pathway could be created, and you guys might already be on to that, especially when a lot of practices these days I've seen are doing Cologuard or fecal immunochemical test. I think part of that has to do with the fact that they have to meet their quality metrics. So that's an easy thing for them to do. So maybe something like that can integrate that part of their practice to the gastroenterologist. So this way, if it comes back positive, automatically, they send over all the paperwork and everything. Appointment is scheduled. Colonoscopy, of course, takes everything through the prep process, and then the results go back.
I think that's a great idea. We are adding that pathway as part of colorectal cancer screening program for our health plan. So one of the things is I can discuss to actually release it and map it for the community practice. And if you want to, Gaurav, you on this team, actually, if they want to advise on that part, we can just create that program and see and launch it. Because then it closes the loop completely, right? There's a very big gap. You're absolutely right. In fact, on Cologuard, 30% of Cologuards come positive and primary care doctors never are able to refer. So we are actually worsening in some way. These patients are higher risk than usual. So I think that's a great idea. So let me revert back on that and see what we are developing here at UC Davis, and we can expose that through this platform. It's a common platform we are working on as well at UC Davis Health, University of Chicago, Cleveland Clinic, Mount Sinai. So anything we built automatically gets released to this platform. So that's additional benefit in that regard.
Awesome. So let's see, does anyone have any questions?
Especially anything major, I would love to hear about any major pain problems that you have, challenges in your practice. And even if solutions are not created, we can potentially think about it. I think that's the very exciting part for the discussion as well. So what are the major things you're struggling, which I may not even have covered, and maybe it's in my left field?
I can maybe mention quick two ones. One is I'm thinking about incorporating principal care management in the practice. So that is something you guys, if you're not already working on that, maybe look into it. The second thing is, I remember actually Brennan Spiegel from Cedars-Sinai published this in the Red Journal a few years back. There's an automated way of populating the history, the HPI, history of present illness. So when the patients come in, they interact with the computer. And this way, by the time you're ready to see the patient, most of, if not all, of HPI is already populated. So that will save a lot of time as far as gathering. Basically, a bunch of those are questions. If you have pain, where is the pain, radiation, all the standard questions, but it takes time. But if we can find a way of doing that without needing our input, I think that would be awesome.
Great. So I'll note of them. So there are technologies now with ambient intelligence, but that is based on the discussion you do. But there are also technologies where you can actually have a bot interact with the patient at home and kind of generate an automatic script. So very relevant efficiency tools. So thank you. Do you want to elaborate on the principles of practice you mentioned?
The principal care management, which is the same, which is the corresponding thing for chronic care management. So CCM used by primary care doctors. Principal care management is what specialists can use. It's a CMS program.
I see. So that is great because we already are supporting CCM and remote patient monitoring through Medicare. So I can look into that, what we can do from a subspecialty specific home perspective.
Awesome.
And this is a billable code, I imagine, like CCM.
Yes. If you just Google that, you'll see it.
Perfect. Thank you. Any other questions from anyone or pain points you want to share?
I had a quick question. One of the banes of our existence is, not only doing this colonoscopies, but reviewing these tubular adenomas, TBAs, protocols based on guidelines on when the surveillance colonoscopy should be. Do you have anything that you've created sort of with AI machine learning that'll actually pre-populate? So it really becomes so time intensive and really not the most exciting part of my day.
Yeah. Now, Bharat, you're hitting something very interesting. We have started working on this. The key gap which we have found is we can take the logic to a decent degree based on the current status, but a large part of that is the past status. And if there's no readily available information on the past status, which also includes family history in one place, then the bot cannot be very accurate, the AI bot. So that is a challenge we are struggling with. But why don't I take a note of that and kind of share, if there is information on family history, past history available in one place, then the bot becomes very accurate. So the question is, in some practices it will work, which have things at the same place, but in some practice it will take it halfway through, but may not be able to take full way through, which may still be fine. At least it reduces the pain by 50%.
Right.
Yeah, that's right, because you got to take into account the preparation quality as well. And to make matters even worse, Bharat, came up with the new guidelines. What was it, last year? No, the year before, 2020. So now, with 1 or 2 small adenomas, you can go up to 10 years, 7 to 10 years, as opposed to 5 before. So
Yep.
now these days I'm like thinking about, okay, which one to do, because you train with one set of guidelines, you're used to one set, and now suddenly things have changed.
Yeah.
And you also don't want to make an error on the other side. When you let the patient go, not earlier off, and then you realize, oh my God, this person should be seen earlier. So there is, but these are good pain points. I think at some stage they will be all addressable to some degree. So I'm taking notes of that. Any other things? I know I also want to be sensitive of your time. You're probably a couple of hours later than me. So you're getting late into the evening here.
All right, folks, if we don't have any further questions for Ashish, I think we should wrap it up.
Appreciate the presentation. Thank you.
Yes, we'll do that. I'll work with Kai to share that presentation. Thank you so much for having me. And thanks for engaging.
Thank you, Ashish.
Thank you. Thank you very much.
Thank you, everyone, for attending.
Thank you.